Unmute. There we go. Good evening, everyone. Thank you so much for joining us again at Wax and Clinical. We're really excited for tonight's webinar. We're being joined by Dr. Zaheer Laher, who's going to be giving us a presentation on navigating nephrotoxins and drug interactions. Dr. Laher completed his medical undergraduate training at the University of Pretoria, and then afterwards went on to complete his internal medicine residency and nephrology certification at the University of Witwatersrand. He completed his nephrology training in 2014 and was a recipient of an International Society of Nephrology Fellowships, which was hosted at the University of San Diego under the guidance of Professor Ravindran Mehta. He's currently in private practice at Netcare Garden City in Gauteng, South Africa, and he remains passionate about critical care nephrology and cardio-renal medicine. He's also in his free time an amateur barrister and looks forward to engaging with fellow nephrologists over coffee. So thank you so much, Dr. Laher, for making time to present us today. We're really excited for your topic. I'll hand over to you.
Thank you so much. Thank you for the very warm welcome, and thank you everybody for spending this balmy Thursday evening with us at the moment. I'm Zaheer Laher. Zaheer, I prefer that. Thank you very much. And today we're just going to discuss a brief oversight of what we see as nephrologists or intensivists or people in the inpatient setting in terms of what happens downstream with patients in the primary care setting. It is easy to get 1,000 prescriptions, but it is hard to get one single remedy. This is a Chinese proverb from the Han Dynasty, which spanned between 206 BC and 220 AD. And as much as things change and as much as things move in a certain direction, certain primacy in terms of man looking to get healing is still very, very at our primary focus at the moment. And that's essentially what we're going to discuss now, try and get the right remedy and maybe perhaps cutting off on some of the thousands of prescriptions that we have to deal with. The object of this presentation is to give you an oversight of what happens downstream in the inpatient setting after decisions that were perhaps made in an outpatient setting. This is of critical importance because as nephrologists, we're stingy people. We count our nephrons one at a time. We want to make sure that every single nephron can be accounted for and we can keep kidneys going for as long as possible. I have a plastic flip file in my practice, and this particular drawing comes out very often. And it's just a bit of a brief reminder for my learned colleagues in terms of the basic outline of the nephron, which is the essential functional unit of kidneys. Just a reminder, there's approximately 1 million nephrons in a healthy, normal adult. And unfortunately, we slowly lose nephrons. And there's a variety of incidents, blood pressures, nephrotoxins, which sort of play a role in terms of the declining of the nephron total. And so we start at the efferent arteriole. And from the efferent arteriole, there's this glomerular tuft of capillaries, and then the efferent arteriole. As you can see, the efferent is wide, and the efferent is narrow. The efferent is narrow. And when any system has a wide influx and a narrow outflux, there's a buildup of pressure in the glomerulus. And this glomerulus is the driving pressure for the formation of urine. A small amount of protein may enter the proximal convoluted tubules, and that is resorbed by the capillary structures around the nephron. Blood on its whole stays in the capillary network, and subsequently, what happens is protein is specifically deleterious at the moment in terms of Anuri? Protein, sorry, excuse me, sorry about that. Protein essentially is quite deleterious in terms of the thin loops of Henle downstream in terms of causing harm to the kidney. We try and stay away from old-fashioned terminology like acute renal failure or kidney failure. We prefer to use the term acute kidney injury. Acute kidney injury is a clinical and biochemical syndrome reflecting an abrupt change in function. AKI stage is determined by acute changes in creatinine and or urine output. Acute kidney injury occurs secondary to an acute illness. The Kidogi's staging system is a practical, easy to remember staging system which has two components. It looks at the serum creatinine and the urine output. Stage 1 AKI, as you can see in the table, is a creatinine increase of more than 26 within 48 hours and a creatinine increase of between 1.5 to 2 from the baseline. The urine output of 0.5 mils per kilogram for 6 consecutive hours. Stage 2 is an increase of between 2 and 3 from the baseline. And in this case, there is a prolonged decrease in the urine output of, again, 0.5 mils per kilogram per hour. So when we talk about just briefly a 80 kilogram person, we're talking about less than 40 mils of urine for a 12-hour period. Stage 3, kidney injury, is a creatinine increase of threefold, or a serum creatinine in absolute numbers of 354, or if the patient's initiated on renal replacement therapy. Or the urine output definitions for the above is a patient who's anuric or has less than 0.3 mils per kilogram. So we look at 100 kilogram patients. We have a prolonged period of oliguria for a 24-hour period. The most important thing in any situation, as any sleuth, in any detective situation, is to ask the first question is the who and the when. So who is at risk for developing acute kidney injury? People over the age of 65, people that are frail, people with significant cognitive impairment. There might be, difficulty in terms of remembering if medications were taken, and a lack of insight with regards to, taking medication. Diabetes is another risk factor for developing acute kidney injury. People with underlying chronic kidney disease, people with cardiac dysfunction, people with liver dysfunctions, and people with cancer. Cancer is particularly, has a particular role in terms of the nephrology, both with the cancer specifically as a primary pathology causing conditions like tumor lysis syndrome, which which affects the renal function in acute setting. Also, sometimes there's obstructive nephropathy that occurs as a consequence of the variety of cancers. Some of the drugs, the historic drugs, are known to be nephrotoxics. And the new kids on the block are a group of drugs called the immune checkpoint inhibitors. And I think we're all going to be exposed if the funders allow us. Those are having fantastic results in the treatment of cancer. But unfortunately, there's a significant risk of renal dysfunction that we're seeing. In the context of those patients, there's normally a second hit. And that second hit is very often sepsis. Hypovolemia is another reason. Hypotension, and obviously the exposure to nephrotoxins, and that's going to be the bulk of what we're going to discuss. We all know about contrast-induced nephropathy. That's a talk in itself, but it's basically a iodinated contrast, which we use for CT scans or for coronary angiograms, which is another cause of significant renal dysfunction. And of course, major surgery associated with the SIRS response and the various hemodynamic changes. So that's the formal didactic approach. I'm going to try and do something a little bit more informal going forward. We've done a little bit of housekeeping in terms of defining where the nephron is and what do we mean by acute kidney injury. So we're going to try something slightly different going forward. We're going to try and be case study. So we're going to use what we call the SCQA format. So the S is the situation. The C is the complexity or the complication arising from the situation. The Q is obviously the pertinent questions, and A is an attempt for us to answer that. So let's give a go with the first patient that we're going to discuss. Very garden variety patient that you would see in a GP practice. It's a 68-year-old gentleman with metabolic syndrome exhibiting abnormal kidney function during a routine visit. There's multiple potential etiologies for the renal dysfunction, including medication history, revealing over-the-counter analgesics for the management of his gout. And the question we need to ask is, what is the likely cause of the patient's renal dysfunction, and how should he be managed? So here's our patient once again, the 68-year-old gentleman with metabolic syndrome. Again, enalapril-cro at 20 milligrams and a thiazide attached to that at 12.5. The patient's also on simvastatin. He's taking Puricos or allopurinol at 200, metformin as monotherapy. And essentially, ibuprofen is also being taken on a regular basis for the above patient. On examination, his blood pressure is 115/74. Despite having a very, very busy day, his blood pressure was still in the low normal range. His pulse rate was 65. He had a weight of 86 kilograms with a height of 1.67. I haven't calculated his BMI, but it's probably about 34 as such. When you look at his labs, he's got a creatinine of 133. His uric acid is elevated at 0.54. His hemoglobin is fine at 14.6, and the HbA1c of 6.8. Additionally, we did a dipsticks, and it was completely normal. We also did an ECG, and the ECG didn't really show much signs of left ventricular hypertrophy, and essentially the ECG was in sinus rhythm. So we can say, obviously, we've noted that the uric acid is high, and as a consequence, this may be precipitating his need for anti-inflammatories. He's taking regular over-the-counter drug use with daily ibuprofen and those magic gout bombs, which makes him feel instantly better. He's on a high-risk combination. He's taking an ACE inhibitor combined with a thiazide diuretics. Important to remember that thiazide diuretics also in its own right will increase the uric acid. So we do have a bit of concerns in terms of his, his combinations, especially with the ibuprofen. I think this very basic diagram is incredibly important to understand. It's showing the interaction and between an ACE inhibitor, ARB, and an anti-inflammatory. So if you look at it at a very basic mechanistic view, you look at the anti-inflammatories, and the anti-inflammatories constrict the inflow. So you're having a slower, decreased constricted blood volume, which is entering the glomerulus. If you look at the ACE ARBs, it's doing the opposite. It's dilating. So blood is entering the glomerulus slower and leaving quicker. And this is resulting in reduced renal blood flow, and it's increasing the risk of glomerular hypoxia. So when patients are on both anti-inflammatories on a regular basis and an ACE and ARB, there should be a high index of suspicion for harm to the kidneys. Unfortunately, with anti-inflammatories, that's only part of the story. The story with anti-inflammatories is much more significant. Anti-inflammatories in high-risk patients are the ones we mentioned earlier. These patients, the high-risk patients that we discussed, they shouldn't be on regular anti-inflammatories. The issue in terms of harm is quite significant with regular anti-inflammatory use. And as we discussed earlier, we have a fixed nephron volume. We have a fixed endowment from our parents, and that endowment should last us for the rest of our natural life. So we should be extremely careful when we make choices. Getting back to the anti-inflammatories, as you can see on the diagram, it causes acute kidney injury secondary to papillary necrosis with a significant vasoconstriction which occurs. This causes, this constriction results in sometimes sloughing and obstruction of the tubular system. And then the second thing that it causes very often is acute interstitial nephritis, which is a type of allergic reaction. There's a proliferation of eosinophils. We'll see an example of that a little bit later. Then we might even just see a nephrotic syndrome, a good old-fashioned nephrotic syndrome as a consequence of anti-inflammatory use. The anti-inflammatories cause significant podocyte injury, and there's a subsequent immune process. So you have a good old-fashioned nephrotic syndrome as a consequence of an over-the-counter anti-inflammatories. It may cause hyperkalemia, and hyperkalemia is an added issue if you think about the implications of being on an ACE inhibitor or an ARB in terms of two different agents which are increasing the potassium. This occurs because of a drop in the GFR and decrease of the renin-angiotensin-aldosterone system. Hyponatremia is also a very common side effect of anti-inflammatories, and it results in an increase in ADH production. There's also sodium and chloride retention with anti-inflammatories, and this contributes directly to both hypertension as well as edema. So let's get back to our index patient. So what's the plan? So the plan is obviously we stop the anti-inflammatories, all right? And the second plan, we need to try and get on top of the pain cycle that the patient's in. So we decided to add the patient on a little bit of colchicine. We started on 0.5 milligrams BD of colchicine, and we told them, we know you're in a lot of pain, so we started an opioid-based analgesia due to the severity of the pain that was evident. In cases like this, we sometimes also can use a low dose of corticosteroids to numb the inflammatory response, and we can slowly start increasing the allopurinol dose. Remember, rapidly increasing allopurinol dose will have a paradoxical response and actually can result in a worsening of the symptomatology of gout. Angiotensin receptor blockers directly lower the risk, directly lowers uric acid levels and can be considered an adjunct in terms of the global total treatment of hyperuricemia and the above patient. There's a very big circle which I missed, and my wife is not going to be too happy about it, is refer to a dietitian, because a dietary intervention in this particular case is incredibly important. Moving to a more plant-based diet will definitely have an effect, and having a careful discussion both in terms of the dietary approach to stop hypertension or DASH diet, in terms of a global view of reducing the uric acid burden. I would also, in the acute context, just for a few weeks perhaps, run the blood pressure slightly on the higher side. And if we need to use something which is a little bit more neutral, a little bit more forgiving, perhaps something like a calcium channel blocker, like a low dose of nifedipine or Amloc, to try and keep the blood pressures in a safe zone. An SGLT2 inhibitor is also a good option. We did mention that the patient has has metabolic syndrome and is on monotherapy with gout. We already have the signal of abnormal kidney function. Like all organs in the body, when there is an abnormal kidney function, there's scarring that has occurred in the kidney. So you can assume there's a degree of scarring. The funders might not agree with us, but I would think it would be a good time to start the patient on an SGLT2 inhibitors. SGLT2 inhibitors also have a mild anti-uric effect as well in terms of lowering the uric acid. It will help us a little bit in terms of lowering, obviously, cardiovascular risk. It will confer to us renal protection, as well as there'll be a little bit of weight loss that would be seen. So assessment of the patient, I think it's quite straightforward. I think we can all agree it's most likely there's analgesic. It's a multifactorial, would be fair to say, with analgesic nephropathy, especially with concomitant therapy of both anti-inflammatories and the ACE inhibitors. There could be a component of hypertensive nephrosclerosis and diabetic kidney disease. Normally, typically of diabetic kidney disease, a urinary protein is present, but bearing in mind that the patient is already on an ACE inhibitor, we could have masked the proteinuria that would have ordinarily occurred. Let's go to the next ground. So we've another typical GP scenario. We've got a 30-year-old female. She's on an aeroplane and she's hounding the general practitioner for antibiotics because she can feel a urinary tract is coming. She refuses to come to the rooms, and it's an absolute emergency. And the general practitioner succumbs and writes a script for Bactrim. And despite the improvements in the dysuria symptoms, routine blood tests are performed and they show an increase in the serum creatinine. And the question is, what is the likely complications causing the abnormal findings, and how should it be managed? So as we said, the initial presentation was dysuria, presumed UTI, but remember, no formal testing has been done, no dipstick, no microscopy. The patient was treated with TMP SMX, Bactrim as we call it. There was an improvement in the dysuria, and after she came from a trip, she was feeling a little bit flat, but the symptoms of the dysuria had improved, and a urine dipstick was done at that stage, and it showed a 1+ blood, 1+ protein. Leukocytes were present, but there were no nitrates. A formal urine MCNS was also performed, and it was very similar to the dipsticks in terms of showing a little bit of protein. But of note, the patient was culture negative despite being off the antibiotics for a period of time. However, the creatinine was 212 in an otherwise healthy young lady. And the estimated GFR was a worrying 28 milliliters per minute, and there was urinary protein of 0.7 grams per gram. So approximately 2 weeks after seeing the GP, a formal consult was done with the nephrologist, and the creatinine at this stage had elevated to 232. And the urine dipstick, again, was very similar to the findings that were seen initially in the general practitioner's office. Additional findings on the clinical exam was that the blood pressure was well controlled, 130/84. There was no arthritis, rashes. There was nothing really systemic that we could find. I asked for additional blood testing in HIV, ANA, for lupus, hepatitis B and C, ASO2, and all of those were essentially negative. We weren't sure what caused the renal dysfunction, and we performed a kidney biopsy. And it essentially showed the diagnosis of what we call an acute interstitial nephritis. Acute interstitial nephritis is basically a biopsy diagnosis which shows a proliferation of eosinophils, which obviously the hallmarks of an allergic type of reaction. There was also a tubulitis or increase in inflammatory cells in the renal tubules, which are seen on kidney biopsy. The patient, because of the age of the patient and the significant renal dysfunction, we elected to treat the patient with steroids at 1 milligram per kilogram. So we gave the patient essentially a starting dose of 60 milligrams of prednisone, and we rapidly tapered and stopped it over 8 weeks. We did a follow-up creatinine on the patient at the end of it. And fortunately, the urinary protein had disappeared and the patient's creatinine had normalized to 66. And what we can say from the kidney biopsy, we've got a biopsy-confirmed diagnosis of acute kidney injury. So this is again showing the complexity and the multitude of potential pathology that can occur as a consequence of regular over-the-counter medication. As you can see, Bactrim is overrepresented in articles with a variety of potential areas of harm. It can cause the acute interstitial nephritis that was essentially diagnosed now. It can cause ATN, which has a different histological pattern, which shows sloughing and degradation of the tubular cells with significant obstruction, which is also seen. A variety of antibiotics and indeed antivirals specifically can cause a crystal nephropathy, and that can also cause tubular obstruction and a rapid decline in kidney function. There's also a variety of other mechanisms of acute kidney injury with antibiotics. Colistin, as we will see in the next slide, is particularly harmful. In the inpatient ICU setting, if the patient's been placed on colistin, you as a nephrologist, you stay quite close to the peripheries just to wait for that moment in terms of that rapid degradation. Colistin, as we know, is a class of drugs called a polymyxin, which is used for the treatment of severely refractory gram-negative sepsis. Bactrim is coming again, and it shows it directly affects tubular secretion. So, and that also manifests in an increase in creatinine. Vancomycin, another very well-known nephrotoxin, causes increase in free radical production. And cephalosporins, and sometimes, and we have seen it causing a hemolytic anemia. I've seen somebody in the inpatient setting that said a hemolytic anemia, and the likely agent was the cephalosporin that was produced as well. This is a handy drug. It's basically from the Food and Drug Administration in terms of the significant risk of a class of drugs and what's the likelihood of causing acute kidney injury. I think it's quite helpful, this graph. It just shows us essentially that the polymyxins, that's the colistins and the like, by far has the highest risk of causing acute kidney injury in terms of the utilization of the drugs. The reported incidence is extremely high, anywhere between 8 and 60%. The immunoglycosides, as we know, are also, especially if they're not routinely monitored, can cause acute kidney injury. Vancomycin, as we know, we discussed it briefly earlier with the toxic metabolites, a very common cause. Bactrim, for an oral agent, it's probably one of the more common causes of acute kidney injury. Penicillin is not benign. We do see acute kidney injury with penicillin combinations, your augmentins, your straightforward. there's no clear difference between the risk of AKI in the variety of agents we see. Clindamycin, cephalosporins would also finish off our table in terms of causing a risk of acute kidney injury. Second patient that we're going to see, and I think this is an interesting patient. You know, we're beginning to see this in the inpatient setting quite a bit. We've got a 64-year-old gentleman. He's well-controlled type 2 diabetic and hypertension. He's scheduled for a sort of semi-elective coronary artery bypass graft. On the third day post-coronary artery bypass graft, an increase in the respiratory rate is noted, and the patient has a severe metabolic acidosis with normal blood glucose levels. The question is, what is the likely cause of this unexpected metabolic acidosis, and how should we manage it? So the answer is a volemic diabetic ketoacidosis. I think this is an important take-home message. We increasingly going to see this complication manifested as the increased utilization of the SGLT2 inhibitors are coming into the general practice. SGLT2 inhibitors are absolute game changers for nephrologists and cardiologists in terms of decreasing the risk of organ failure from both the cardiac and for a renal perspective. And we're very supportive of their use in appropriate patients and settings, but it does come with a little bit of care in certain circumstances. Getting back to our index patients, as we said, day 3, he's a 64-year-old gentleman, type 2 diabetes, hypertension, dyslipidemia, ischemic heart disease with an EF of 41% pre-op. He had triple vessel disease, and it's requiring a coronary artery bypass graft. Because of his relative age, the cardiologists, the cardiothoracic surgeons did an arterial graft as opposed to a venous graft. The benefit of an arterial graft is you can expect a longer duration of action and longer half-life with an artery as opposed to a vein. However, it does somehow come at the cost of the amount of time or the duration of time that you spend on bypass. Bypass in itself can have an effect on kidney function. His chronic medications include valsartan at 160 milligrams. He's also on Aspervol at 40. He's on allopurinol at 300. He's on metformin. He's on empagliflozin at 25 milligrams. His aspirin is at 81. His blood pressure is 120/84. Of note, his pulse rate is of 134. His weight is 93. And his respiratory rate is at 26 beats per minute. Now, just, one of the things that I sometimes, I always speak to the nurses is to do a quick SOFA on unstable patients. So you do a quick SOFA essentially is to look at the systolic blood pressure and compare that to the pulse rate of the patient. So if it's at 1, close to 1 or greater than 1, it's sometimes a sign of intravascular depletion, that this patient is in trouble. So I'm just going to reiterate again. So if the systolic blood pressure is close to your pulse rate, your patient is in trouble. And in this particular case, the labs that were done shows a creatinine of 122, the pH was 7.2 showing acidosis. The blood glucose of note on this patient showed a blood glucose of 6.5. The base excess was -10. The bicarbonate was 12. The hemoglobin was 12.6, so there was no acute blood loss. The PO2 was 87, so there was no hypoxia. The PCO2 was 35, and the HbA1c was 6.2. So it's showing that the patient pre-operatively was well managed in terms of getting appropriate treatment in both the metformin as well as the SGLT2. So essentially what we did with this patient, we checked the urine dipsticks, and the urine dipsticks showed in a normal glycemic patient ketones. We did an ECG to check if the patient was having a new myocardial event, which he wasn't. And we decided to increase the fluids. We elected to give the patient 5% dextrose in a cocktail with sodium bicarbonate at 80 mL per hour. Because of the cardiac status of the patient, we were a bit reluctant to be overly aggressive in terms of resuscitating the patient. We also started an insulin infusion, and we gave additional boluses of 50% 20 mL dextrose water. Essentially what we tried to do with the dextrose waters was ensure that the glucose was between 10 and 15, so it gave us enough of a safe room to give an insulin infusion. So we could use so we could essentially treat this patient as a DKA by giving the patient additional, and that's basically the key for treating these euvolemic diabetic ketoacidosis. So let's go briefly and talk a little bit more about the euvolemic DKAs and the role of SGLT2 inhibitors. Essentially, there's a carbohydrate deficiency which leads to reduced insulin glucagon, reduced serum insulin. There's a surge in counter-regulatory organs, specifically glucagon, adrenaline, and cortisol. This results in biochemical consequences, specifically an altered glucagon-insulin ratio, which promotes lipolysis, resulting in an elevation in fatty acids and the initiation of your ketotic cycle. SGLT2s inhibit renal glucose reabsorption. They also induce glycosuria, and they also increase the production of glucagon. So it also secondarily increases your glucagon or your counter-regulatory system. And the clinical presentation of a euvolemic ketoacidosis is typically with glucoses of less than 11. DKAs generally, they're much higher. I've stated 13.9, but generally a little bit higher than that even. The clinical manifestations is the metabolic acidosis accompanied by the respiratory compensation, which our patient had. There was additional symptoms. There was nausea and vomiting, which only exacerbated our cycle of intravascular depletion and metabolic acidosis. The risk factors is there's an increased risk in patients with surgical interventions in terms of acute illness, dehydration, and alcohol consumption. Obviously, there should be the immediate cessation of the SGLT2 inhibitors. Some of the cardiothoracic surgeons, some of the cardiologists, they like to start aggressively the SGLT2 inhibitors. In patients like this, I would exercise a little bit more caution in terms of giving restarting the SGLT2 inhibitors. We obviously gave the fluid resuscitation, which has been given, and we can expect markedly abnormal electrolytes, and we need to be on top of that by regularly checking the acid-base gases. Again, in terms of clinical vigilance for these sort of patients, we should screen for high-risk patients for ketones, even when there's a metabolic acidosis. And that doesn't only work in the post-op. Even if a patient is in the outpatient settings, had nausea, vomiting, is on an SGLT2 inhibitor, check the glucose quickly and have a look at your ketones. And and in a case like that, within SGLT2 inhibitors, there's a place for giving people treatment holidays. So, you advise patients, this is a wonderful drug, but if you have an acute diarrheal process, which is quite significant, lasting more than 24 hours, or you're feeling dehydrated, give the drug a dose. That also goes for ACE inhibitors and diuretics. We should be sort of giving patients a bit of a heads up in terms of which drugs to be careful with. This is a updated warning from the Food and Drug Administration, and it's basically stating after measures, to lessen the risk of developing ketoacidosis. It's quite a recent FDA update, and it states that to lessen the risk of developing ketoacidosis after surgery, the FDA has approved changes to the prescribing information for SGLT2 inhibitors. Professionals should consider stopping the SGLT2 inhibitors at least 3 days before surgery. Next patient. I think there's a reasonable amount of awareness in terms of patients like this. So here we've got a 34-year-old patient. She's HIV positive. She's been on ARVs for 6 years. She presented for routine follow-up with the general practitioner. Her creatinine was done, and it showed a creatinine of 87, slightly low, but nothing massively deranged, with an eGFR of 77. There was 1+ of glucose on the dipstick. There was no evidence of protein. There was nothing else, essentially. Because it was an excellent healthcare practitioner, she kept good tabs on her patient. Said, please pop in about 3 months. We'll do another set of bloods. I don't like the fact that your GFR has dropped a little bit. And the general practitioner did a 3-month follow-up and saw that creatinine at this stage had increased to 134, indicating renal impairment and significant renal impairment in an otherwise healthy. And the most likely diagnosis was tenofovir nephrotoxicity, causing a proximal tubular dysfunction. And the question we're asking is, could the elevated creatinine and glycosuria be early signs of tenofovir-induced nephrotoxicity? And would a regime change improve renal function? The patient was subsequently transitioned to a tenofovir free regimen, leading to a significant improvement in renal function, and the creatinine reduced to 77 with the GFR, which was close to normal after 3 months. Now, the proximal tubulopathies, or, it's part of a condition called a Fanconi syndrome. You might remember that in terms of the causes of metabolic acidosis. Patients present with polyuria, polydipsia, vague tiredness because of the hypokalemia that's present. There's very often hypophosphatemia. In terms of early signs of tenofovir nephrotoxicity, the fractional excretion of phosphate is probably the most underutilized but the most sensitive marker of tenofovir nephrotoxicity. Glycosuria in a non-diabetic should immediately ring a bell of tubular dysfunction, and consideration should be given to look for tenofovir nephrotoxicity or other causes of Fanconi's-like syndrome. The urinary protein is a much later sign of tenofovir nephrotoxicity because, remembering the nephron, we have relatively moderate or minimal proteinuria in tubular dysfunction compared to glomerular dysfunction. So you do have proteinuria, and it's a much later sign. The creatinine is obviously a much later marker. The risk factors for developing nephrotoxins is the concurrent use of other nephrotoxic drugs, and obviously a lot of the risk factors that we discussed earlier. There's also the concept, which is widely known in nephrology circles, of the APOL1 polymorphism. So we all know about the survival benefit of sickle cell anemia in high incidence areas of malaria. Like sickle cell, in terms of an adaptation, was shown to have been beneficial for developing malaria. Similarly, an APOL1 polymorphism has been shown in sub-Saharan Africa to be beneficial for developing African tsetse fly or sleeping sickness. However, it still unfortunately is very poorly located in a similar area which codes for glomerular repair, and it's thought to be part of the reason that we see accelerated hypertension, hypertensive heart disease, accelerated renal dysfunction in patients of sub-Saharan descent. These same populations, very often when they tested in the US, have polymorphisms for APOL1. It would be lovely to test our patients for APOL1 polymorphisms because it would have impact in terms of which patients should be at high risk for, for monitoring and for close, more rapid referral to specialists for advanced care. And as we stated, ultimately, a diagnosis of tenofovir nephrotoxicity is made on a kidney biopsy, and you can see there's four different examples of nephrotoxicity. If you look at A, there's a lot of simplification of the proximal tubular cells. There's a loss of some of the sophistication, and you very often see that in the early stages of proximal tubulopathy with tenofovir. The second slide shows, and if you can look at, there's lots and lots of scarring. So this particular patient has probably been exposed to tenofovir for a long period of time, causing significant scarring and tubular atrophy. You don't want a patient with tenofovir nephrotoxicity to progress to slide B because it will confer a worse prognosis. And getting back to it, remember, you don't want to destroy your spending money of nephrons very early on in life. You still have many years to go, so you want to look after our nephrons. C is showing proliferation of eosinophils, and inflammatory cells in the tubule, and D is showing large mitochondria and mitochondrial dysfunction again in the proximal tubular cells. Enough of histology. I'm not going to show you any more histology. Next patient. And this, I think, is quite important. It's sort of going to lead us to one of our last case studies. We got a 46-year-old patient who's had a cadaveric transplant. He's 6 years post-transplant. He's had stable graft function with no episodes of rejection since inception. And he presents with a 4-day history of upper respiratory tract infection. He normally sees his nephrologist twice a year because he's been stable. This year, he managed to get away and just see the nephrologist once a year, and he had stable blood results. There's nothing really of worry. So he's basically hasn't seen his nephrologist for about a year. And he contacted his general practitioner because of his upper respiratory tract infection, and the general practitioner gave erythromycin. 2 days later, the patient's emergency department is critically ill, he's confused, he's possibly post-ictal, he might have had a seizure, and he is admitted to the emergency department. Question is, what is the likely cause of the patient's critical condition, and how should it be managed? The answer is tetrotoxicity. There's likely tetrotoxicity. They did a random tacro levels, and tacrolimus levels were sitting at 18. Generally, on patients which are with stable function, we look at trough tacrolimus levels of around about between 5 and 8, 5 and 7, 6 and 8. So this is markedly abnormal. The creatinine has increased substantially. It's 264. It was previously 108. The CRP and PCT are flat, showing no signs of significant sepsis. So what are we talking about now? So we're talking about drug-drug interactions. So we're briefly going to use this as an opportunity to remind our colleagues about the cytokine P450 enzyme system and the key players which are key players in terms of drug metabolism. The most significant enzymes are the CYP3A4, which is associated in tacrolimus degradation, and it accounts for these two enzymes account for approximately 90% of the metabolism of patients in clinical practice. So essentially, just a brief reminder. So there are different polymorphisms based on different racial characteristics. At the extremes, we talk about poor metabolizers. These are patients with an inability to metabolize drugs. These patients risk adverse toxicities because you have an accumulated toxicity because the drug has nowhere to go. It just keeps on accumulating and results in toxicity. It's been suggested that it's present in up to 30% of patients which are ethnically Chinese. On the other end of the spectrum is the ultra-rapid metabolizers. These are the patients that lack they have a lack of response to medication because basically it's metabolized as soon as it enters the blood system, and these are very often evident in patients of North African and Arab descent. If you look at it in terms of prodrugs are obviously, it's exactly the opposite. So prodrugs are drugs which require a first pass effect in the liver. So if you're a prodrug and you are a poor metabolizer, you're going to fail to convert into an active metabolizer because you're not going to be able to convert the drug into an active form. So you're going to have no therapeutic response. But similarly, if you're an ultra-rapid metabolizer, you're at very high risk for developing toxicity to the drugs. So in this case, we've got a macrolide-induced tacrotoxicity. Erythromycin is a macrolide antibiotic that inhibits the CYP3A metabolism and cause increased levels of tacrolimus. Checking for potential drug-drug interactions is key, especially there are some very, very good online resources. Basically, you just step in the different drugs. I use the one, the LexComp, which is very easy to use. It's part of the up-to-date program, which, it's very much a go-to program. But other important day-to-day drugs which cause interactions, which can increase serum concentration of your tacrolimus or your cyclosporin, drugs like amiodarone, the ARTs. Fluconazole is a very commonly used drug which can cause absolute catastrophe for patients. The HIV protease inhibitors should be used with absolute caution in patients in transplant. The macrolide antibiotics, as we discussed, and the non-hydropyridone calcium channel blockers, that's your verapamil. Some of the HSV drugs, and obviously grey juice. We'll always remember that when we're giving counseling with regards to warfarin, which works on a similar system. The anti-seizure drugs have the opposite impact and can result in subtherapeutic tacrolimus levels, which can result in rejection. Essentially, rifampicin is another typically used drug which can decrease the immunosuppression interest and increase the risk of organ rejection. And St. John's wort, which is, I think it's out of fashion. I don't know, I haven't heard of anybody taking St. John's wort recently, but it's another drug of concern, or a herb of concern. So why are we having this conversation? And I think we need to have a global perspective. Kidney failure is an increasing absolute catastrophe. There's a shortage of nephrologists in South Africa. There's a shortage of nephrologists worldwide. There's a shortage of resources worldwide. It's one of the highest drivers for cost in the healthcare system. Nephrology and dialysis services, combined with cardiovascular and cancer, eat up the bulk of the healthcare budget. And, this is a very interesting study, and it's an eye-opening study to look at. The 5-year survival of patients on dialysis is 50.8% compared to prostate cancer, which is far better at 83.3%. Colorectal at 56.1%. It's better than some of the really nasty, like small cell lung cancer and pancreas cancer. But there's very few cancers which do, so a dialysis diagnosis is akin to a cancer diagnosis. Unfortunately, it's much worse than a cancer diagnosis. This goes for men and women. And if you go over the age of 70 and you're on dialysis, the survival rates are even more terrible. And your survival rates are very similar to people with lung cancer and pancreas cancer. And, I think I can't be a nephrologist and I can't love my nephrons in terms of doing a bit of a public service announcement. We have about 4,500 listed patients. Maximally, 300 procedures are done per year. 4,500 listed patients. To be on a kidney transplant list in South Africa, you've almost got to be an Olympic athlete to get on it. So 4,500 people are listed, but there's a huge population of patients which we don't even bother listing because we know realistically they're not going to get a kidney because there's no availability. So approximately 300 procedures are done. So you just look at the ratio. And unfortunately, over the last 15 years, there's a real decline, not just in per capita amount, but there's a real decrease in the amount of transplants which are being done. There's a variety of reasons for that. There's there's socio-cultural reasons. Again, like patients are not candidates also because of declining health outcomes. But we are in a country with a large youth population. We are a country with large amounts of trauma, both violent crime and motor vehicle accidents, where we are burning, we are burying very viable organs into the ground. So I think it's important for us as healthcare providers to have those conversations with people and say, up to 7 lives can be positively affected by every person that's with every transplant that's been done. And we do have a society, we need to start having those conversations in terms of NHI, whether we're going to be doing what some of the European countries are doing, which is the opt-out system. In terms of healthcare affordability, if we do an opt-out system, it might increase the chance of healthcare affordability by increasing the rates of transplant. What do we mean by the opt-out system? That everybody is a de facto organ donor unless they've taken the time and trouble to be registered as a non-donor in the country. Thank you very much for the opportunity, and thank you for organizing in such a delightful way. And I hope that was helpful, and I hope we still have some guests on the other side and they haven't run away.
No, they still have a full room. So I just forgot to make a notice that you're welcome to type your questions in the chat, or you can ask them in the Q&A, whichever you prefer. But thank you so much. That was incredibly informative. I think, a lot of really useful and practical advice. And I think what we'll do now is we'll just wait and see if there's any questions that are coming in the chat. I was so enthralled. I normally have a little message that I write in the chat, but it was a very, very great presentation. So if there's any questions, we're welcome to type questions in the chat. But Jock, thank you for that. And thank you for the case studies. I think they were a very practical way of putting across the information and really just how it can be applied in a clinical setting. I think while we wait for the questions sort of coming up in the chat, one question that I sort of had was that it was interesting, the study that you showed, the last study around the sort of 5-year mortality or survival rate, let me say rather, for patients with dialysis versus patients with cancer. And I guess it's more of a philosophical question, just sort of understanding from a nephrologist point of view, considering that sort of survival rate, what is sort of the counseling that is given to a patient when they're put on dialysis? Because, you know, if I think of the engagements with the patient when they're diagnosed with cancer, it's a much more how can I say, pressing engagement, because there is this idea of mortality. But I don't know, is that the same sort of engagement when patients are going on dialysis?
Unfortunately not. Unfortunately not. It is one of the, you know, we very much, we don't have the same global resources in terms of counseling that's offered to patients in the cancer setting, and we should be. Because, you know, there was another study that looked at chronic hemodialysis patients, and the incidence of anxiety and depression is between 40 and 60%, which is, which is hugely burdensome on, on some of the patients as well. You add also one of the other hallmarks of chronic hemodialysis patients. They all have, significant sleep abnormalities, and it affects their, the sleep abnormalities directly, relates into cardiovascular outcomes. It directly, attributes to mood outcomes. And also, unfortunately, with dialysis patterns, if you had to overlap some of the pathophysiological changes that you see in Alzheimer's disease, beta amyloid production. And also one of the things that you see in dialysis patients is your glymphatic systems, or the clearance of neurotoxins from the brain, is massively impaired. So you're having accumulated neurotoxins, and we see that with the dialysis patients, where unfortunately there's a steady decline in cognition, mood, and sometimes as nephrologists, I'm punting transplantation, but we see these people suffering on a day-to-day basis. We see some of them coming in with a degree of optimism, and you see them withering away. So it's actually, sometimes it's absolutely tragic, and it's heartbreaking. And if you look at the survival curves, there's a lot of pain associated with dialysis. There's vascular access, there's needling of fistulas, there's stolen time in terms of 3 times a week, 4 hours. There's systemic problems like machines that are not working. In Gauteng, we're sitting with water issues. You need water to dialyze patients as well. There's concerns about sepsis. In terms of COVID pandemic, our dialysis populations were decimated in certain settings because you cannot do the degree of social distancing that you would like in a dialysis patient. And these are the patients which are most likely to pick up significant complications of dialysis. So recently I was in Mecca, and I made a sincere prayer to the Almighty. I said, of the things that can affect me, please protect me from the harms and sins, and just keep me away from dialysis. You really can't help but empathize with the pain and suffering that patients are going through on a daily basis.
Oh, no, thank you for that. And I see there's also a comment here from, we have a clinical psychologist who's in the meeting as well, and also mentioning that, and really sort of highlighting what you're saying, that, patients don't necessarily always get that psychological assistance, or don't necessarily always get that referral. So just mentioning that, it's great that highlighted, because I think it is, I guess, sort of, not necessarily spoken about as much as it is in other sort of settings. So that's quite, thank you for mentioning that. I'm not sure if there's any other questions or comments. I'm not seeing anything else come up in the chat. Okay, I think we'll then close it there then. Oh wait, there we go. Sorry. So there's a question here saying, what can be done to advise doctors to screen? Sorry, let me just read this if I. Okay, yes, what can be done to advise doctors, or what advise to doctors to screen, swab, or take bloods before prescribing antibiotics? So this person is mentioning that they had a doctor at their hospital who used to do that, and was expensive and unnecessary, but he made sure that he was on the appropriate one when prescribing. So really just kind of speaking to some of the complications that you mentioned, are there any precautionary measures that can be taken before prescribing antibiotics to perhaps try and prevent some of these complications from occurring?
I think clinical context, we mentioned earlier on about the high-risk populations. And in high-risk populations, patients with diabetes, patients over the age of 65, patients with any signs of organ dysfunctions, patients with a history of prior kidney disease. those patients, you need to be more vigilant. And with antibiotics, it boils down to original sin. Do you have an indication for giving a patient an antibiotic? We looked at some of those case studies, and that's, it's what we land up seeing. You're having patients that have near catastrophic side effects with antibiotics that have viral infections. And, so I think it is important to, be more mindful as well. Patients with robust immune systems who can very often fight off infections. So I think, like every medical complication that we're likely to have, it boils down to primary indication.
Well, that's very, very appropriate. I think, definitely sort of echoing the sentiment. Okay, I'm not seeing any other questions come up in the chat. So I think in lieu of that, thank you so much, Dr. Laher. This was incredibly informative. We will be making a recording of this available, but thank you for your time and for sharing your knowledge. It was a really, really great session, so thank you.
Thank you kindly. Thank you again. Have a lovely night.
Thank you, everyone. Have a lovely evening. Bye.